So looking at cardiovascular system. I'm going to continue a tradition that was quite frequent in my graduate school, where lecturers would put a comic at the very beginning. Obviously, heart doesn't like spiders because they're icky. All right, the heart. So we got to talk about some things. The heart, so it sits central in your body, about the size of your fist, and it rests on your diaphragm. So kind of anytime you inhale, you are going to push a little bit onto the area that holds your heart and your lungs, and it's called your thorax. So you have in your thorax just heart, lungs, a lot of veins, arteries, nerves, and you can see that it also sits at an oblique angle. So it's not perfectly in the center, right? So it allows, it influences other structures around it, particularly your lungs. That's why your right lung is larger than your left lung. You have to have space for your heart to pump. And then we have one structure that we immediately talk about is the apex of your heart. And so we can orient ourselves when we're looking at images of the heart. We can orient ourselves using the apex and some of these other structures. So the cardiac apex is right here. This let's do highlight right here. So cardiac apex is right there. You can see that it's kind of the tip, I'll say, of the heart. Kind of where when we do dissections, you'll see where the walls of each of the ventricles of the heart kind of come together, and it's at the bottom, quote unquote, or the most inferior portion. And you can see that there are a lot of the vessels come in and out more on the superior aspect of the heart, whereas the musculature of the heart is more inferior, so that it allows that blood pump to occur. All right. So since we're in the heart, if we just let the heart sit there without any protection, what we're going to end up with is we have a constantly moving muscle inside a capsule. So if we don't have any layers of protection to protect it, it will get inflamed and agitated, and it just won't work. So what the body has come up with is a couple of layers. So first, the outermost layer is this fibrous pericardium. This fibrous pericardium, it's more hard, cartilaginous, kind of like your ligaments, helps the heart adhere to your diaphragm and the vessels. It holds the heart in place, and it prevents overfilling. So you can kind of think of it as a backstop for your heart becoming too enlarged, almost. Although your heart can become enlarged, and we We can talk about that later, but not outside of the scope of this course. So we have that fibrous pericardium. It's really going to help hold the heart in place, help us adhere to the diaphragm, prevent that overfilling of the atria and of the ventricles. And then if we go a little bit deeper, so we have our fibrous pericardium here. And then we have the serous pericardium. So it's a parietal layer. It's deep to that fibrous pericardium. So it is this structure right here, that yellow layer. Serous pericardium, deep. It helps contain the pericardial cavity, and the pericardial cavity has inside of it fluid to help lubricate. So since we have a lot of movement on the heart, if we have it essentially just suspended in a fluid, it will allow it to pump. We won't have that friction on it, and we won't incur as much injury from the regular pumping. And then we have another layer of more kind of tendinous structure. We have the visceral layer of the serous pericardium. So parietal layer being more superficial, visceral layer being deep. It's also kind of mixed with, I'll say, not mixed with. For our purposes, it is the same layer as the epicardium. So if you ever heard, let's talk about like your skin, you have the epidermis, dermis, and endodermis. Kind of the same naming scheme here. We have epicardium. Epicardium is the most superficial layer. Myocardium is where we have the actual muscle of the heart. That's a myocardium. And then the endocardium is the deepest layer in that heart wall, and it interacts with or interfaces with the blood in that heart chamber. So we have a couple different layers of protection. That fibrous, tough, hard sheet on the outside. And then we have this, I'll call it containment layer, the parietal and visceral layer of the serous pericardium. And then inside that kind of shell that is made up of the parietal and visceral layer, we have the pericardial cavity, where we have that serous fluid to lubricate and prevent friction. And then we have that visceral layer is kind of intertwined with the epicardium. And then the actual muscle of it is going to be the myocardium. And then we have endocardium, which is that innermost layer. Isabel. Endocardium is the innermost layer. It'll interface with the actual blood, and we will have tendinous attachments on the endocardium. So when we get to in a couple of slides, we'll talk about other structures that attach some of the structures inside the actual ventricles will attach on the endocardium. So some clinical relevance here, we can see on the left-hand side is a normal X-ray of a patient. And then on the right-hand side, we have a cardiomegaly due to pericardial effusion. So pericardial effusion So just inflammation. So that pericardium, all in that fibrous pericardium, parietal layer, and visceral layer. So all of that inflammation, we can see all that inflammation just taking up a lot of space in that patient's chest. So this can be pericarditis, epicarditis, endocarditis, myocarditis. We can really have any type of inflammation in the heart wall. It can also be an infection or inflammation of the lining of the heart wall, cause adhesions. And so really, if you have any restriction, any adhesion in that, in those layers, it can cause a lot of problems. We can have a lot of agitation because you're pumping at a low end, you're pumping 30 beats a minute. And so that's a ton of movement every day. And so being able to, it can cause a lot of problems. And then if we have a lot of fluid around your heart, what's going to end up happening is if there's enough pressure in there, now we're decreasing the amount of blood that can come through your heart and is being pumped through your heart. So then if we decrease the amount of blood, your heart's going to have to pump more. And then that will feed into the loop of, we're increasing the fluid. Now we have to pump harder. Now we're increasing the fluid around, inflammation around. Now we have to pump harder. And so it's just a self-serving loop until we kind of get that fluid under control. All right. So now let's really dive into this. We have a couple of structures that you're going to be responsible for. So we're going to follow, I'm going to try to remember and follow the path of blood flow here. So first thing that's going to happen is we're going to come into the heart from the veins. And we have two major vessels, two major veins that help transport blood to the heart. That is going to be the superior vena cava and the inferior vena cava. Superior and inferior vena cavas, two major vessels, one coming from the top, one coming from the bottom, and they both dump all of their blood into the right atria. And so on the surface, we can identify the right atria through a structure called the auricle, right auricle. So here's that right auricle. And we can see that on when we dissect models, that right auricle. And so that right auricle is where we have the right atria. Atria are where we kind of have blood collect before it is pushed into a ventricle, the right ventricle specifically. And so then on the surface, we can see the right ventricle. I'm going to outline this here. The right ventricle is going to be right here. And so I can tell, if I back up, I can tell that all of this structure in here, and let me make it just a little bit smaller. There. And I can tell this area is the right ventricle because I can see the anterior interventricular sulcus. And so that anterior interventricular sulcus right here serves as a line that helps me differentiate the right from the left ventricles. The ventricles are where the atria kind of just more so collect and push the blood into the ventricles. The ventricles actually do the work of contracting. Is the walls of the ventricles are much thicker, and they help contract and push the blood either into the lungs in the case of the right ventricle, or throughout the rest of the body in the case of the left ventricle. And so then we have, if I have the right ventricle here, I will have the left ventricle right here. And I can see that left auricle right here. We can also see that cardiac apex. So the apex tip right here. And then we can also see pulmonary arteries and veins. So pulmonary arteries and pulmonary veins right here. Okay, so this is on the anterior side. So now if we move over to the posterior side, we can see, once again, so we have the, let's do superior and inferior vena cavas. Superior and inferior vena cava. So that's where our blood is gonna come through after being used in our body. We will then collect kind of right back in here in the right atria. It will get pushed through the atria into the right ventricle. And hold on. Pushed through a valve called the tricuspid valve. We'll get to valves a little bit later. Pushed from the atria into the right ventricle. And then once we're in that right ventricle, you're welcome. Once we're in that right ventricle, we will be pushed out. That deoxygenated blood, still deoxygenated, we will be coming out of the right pulmonary, right and left pulmonary arteries. So now you might be thinking, well, Mitch, arteries carry oxygenated blood and veins carry deoxygenated blood. Duh, moron. Anatomists are wrong. Well, generally, they do. More precisely, arteries are vessels that carry blood away from the heart, and veins are vessels that carry blood towards the heart. So in that definition, we're a little bit more precise. So that's why you see in this illustration, the pulmonary arteries are shown as blue deoxygenated, whereas these pulmonary veins, you can see the tips there are a little bit more red because those pulmonary veins are coming towards the heart. So if we're moving that blood towards the heart, they are veins. If we're moving blood away from the heart, they are arteries. So coming out of those pulmonary arteries, goes into the lungs, comes back in through the right and left pulmonary veins, gets pushed into, collected really, into the left atria. From the left atria through the bicuspid valve and into the left ventricle. We can see the left ventricle here. We can also see the left auricle right up in here, where that orange line is. Left ventricle, once we get through that left ventricle, we are being pushed out through the aortic arch and into the rest of the body. Let's not do blue. So we get pushed out and we're coming up this way. All right. So the vena cava, we have the aortic arch, atria, and then we can orient ourselves and we can see the apex right down here. All right, so there's the posterior surface. Now, if we look inferiorly, no, we can't. We can't see because the vena cava and pulmonary veins are blocking our view. So we can see it here, but that vena cava is blocking our view. Now, if we look on the inferior surface, we can orient ourselves a little bit and find that apex right there. We also have we have our vena cava right here. Going through that vena cava, collecting in the atria, pushed through into the right ventricle. Right ventricle pushes it out, pushes that blood out into pulmonary arteries. Blood comes back through the pulmonary veins. Into the left atria. Gets pushed down into the left ventricle. And left ventricle pushes that blood up and out through the aortic arch. Other structures you probably want to take note of, this coronary sinus comes off of or dumps blood into the inferior vena cava. And if you've ever heard of someone having coronary bypass surgery, this is one of the vessels that will be repaired. All right, there's that inferior surface. And then last one here, the next one here. So we can see in this view, we have now opened up the right side of the heart and we can see inside it. So we follow our blood here. We're start off with blue. Coming from the inferior and superior vena cavas. And then when we're collecting in that right atria, here's our auricle right here, that pink triangle. And then specifically the structure that allows us to push the blood through into the ventricles and allows the blood to stay in the ventricles without regurgitating back into the atria. On the right side is the tricuspid valve. The tricuspid valve has, as you might imagine, three little leaflets that allow it to hold on, say, to that blood. So hold on to that blood. And they're designed in a way so that when the heart contracts, when our heart contracts, the muscles, these papillary muscles. So if we zoom in right here, we have these papillary muscles right here where we have on the, so the valve itself right here. And then we have these small strands connecting the valve to the papillary muscles. And these are tendinous cords, or as I learned them, chordae tendinae, but you can call them tendinous cords. And they attach onto those papillary muscles. We pull that atrioventricular valve open, let that blood in, that atria contracts, pushes it in as well. And then we close that, we close the tricuspid valve. The heart then, or excuse me, the atria contracts, opens up the atrioventricular valve. It then, after the atria relaxes, the ventricle, right ventricle contracts, and now we are forcing another valve in the pulmonary trunk. So the pulmonary trunk is kind of where the right and left pulmonary arteries originate, because we come from one vessel, we split into two, are the semilunar valves. So once we have blood in the ventricle, it will then, once we contract, flow out through the semilunar valves. And they're called the semilunar valves because, excuse me, because they kind of look like half moons. So they're right here. You can see they're kind of small cups. We will get a better image of them in a moment. So right there, we then will push that blood up, out through that pulmonary trunk and into the lungs. Do we have a, yes, we do have a different view. Pulmonary trunk. So this right side of the heart, you can see this wall is relatively thin. And since its job is to just deliver blood to the lungs, we're not as interested in making sure that we are interested in ensuring that there's enough pressure of the blood to go through the lungs and come back into the heart through the pulmonary veins. But besides that, the right ventricle doesn't need to contract as hard as the left ventricle, because the left ventricle, you have to contract enough to force blood as far away as your fingertips and your toes. So not nearly as thick, just needs to deliver it to the lungs. All right. Any questions so far? Am I going too fast? All right, We'll keep going. So then if we open up the left side of the heart, we can see how much thicker the wall is compared to the right side. So when we're following that blood, we've come from the lungs and we're coming into the atria from the pulmonary veins. We collect in the atria right here, and we're pushed through the bicuspid valve. So on the left side, there are only two flaps, which distinguishes it from the right. So the right side, you have a bicuspid valve between the atria and the ventricle. And then on the left-hand side, you have the, okay, hold on. Right side, you have the tricuspid valve. There are three leaflets. And then on the left side, you have two leaflets. So it's the bicuspid valve. So we're pushed through that bicuspid valve. See those chordae tendineae, as they have named them here, attaching that valve leaflet onto the papillary muscles inside of the heart. Welcome. We then, so here, papillary muscles. Papillary muscles. And chordae tendineae right here. Now, pushing that blood that much thicker wall, pushing that blood up through the aortic arch. Come up and through. And we're pushing it through the aortic trunk. And it will also have a semilunar valve as well. You can kind of see it peeking out right here. But that blood, we're coming in through that ventricle, coming down, and then we're being pushed out and up through that aortic arch. Okay. So then if we, let's say we cut the heart in half, top to bottom, we can see just how much thicker this wall is on the left-hand side compared to this relatively thin wall on the right-hand side. Just really noting, because that left ventricle, we have to push so much blood up and out, and it has to reach so far away. We really have to have a lot of power in order to push it to where we need it to go. All right. So schematically, excuse me. Well, that's the same. Well, I don't know why I have those two. Okay. I do. Okay. So then if we look at the blood flow schematically, we can see a couple of things. So let's start here in this upper body circulation. We come from the upper body circulation, we come down, and we're gonna come through that superior vena cava. We're gonna go into the right atria. We're gonna be pushed through that tricuspid valve into the right ventricle. Welcome. The right ventricle will contract, and we will push that blood out through the pulmonary artery into the lungs, or excuse me, from the pulmonary trunk through the pulmonary arteries into the lungs. We then have pulmonary circulation. We come back through the pulmonary veins. That blood now oxygenated. We collect in that left atria, pushed through the bicuspid valve, We are now in that left ventricle. That left ventricle contracts and we're pushed out through the ascending aorta, through the aortic arch and out to the rest of the body. You can essentially forget about this stuff in here because we're not gonna cover it. Yeah, don't worry about this stuff or this hepatic one. All right, so just worry about all that stuff there. All right, so then let's take a slice. Superiorly, looking at these valves, we have the right atrioventricular valve and the left atrioventricular valve. And we can see these little cusps or leaflets. We have one here, that's 2, 1, and 2, and 3. And then we just have 1 and 2 over here. So when we are dissecting, if you are unsure of if you're in the right or left atria or in the right or left ventricle, you can look to how many leaflets does this ventricle have. If you have 3, you're in the right. If you have 2, you're in the left. Easy peasy. Whereas the AV valves or atrioventricular valves are a little bit more active. They're connected to tendons. They have muscular attachments, and they're kind of opened, quote unquote, manually. The semilunar valves, so the pulmonary and aortic valves, are more passive. So because of their shape, when blood fills up, the blood acts as kind of the sealant to not allow the blood to backfill into the ventricle. And so you can kind of see here on the left and right hand side, when we open that valve, it will allow blood through one way, but it won't allow blood to come back. And so if you have a problem, say one of these valves are damaged, one of your semilunar valves are damaged, that's going to be a problem because you're going to have backflow from either the aorta or pulmonary trunks back into the ventricles, which can cause problems. Yeah. Any questions about valves? All right. We will do we'll keep going then. So once again, operation of our heart valves. So getting a little bit more into detail here. So blood comes, puts pressure on these AV valves. They're forced to open, coming through the atria into the ventricles. Right here we can see. We then, as the blood returns, as the ventricles fill, AV valves cusps hang limply into the ventricles. AV valves open when the pressure in the atria is greater than the pressure in the ventricles. Then once the blood has filled, the ventricles can contract. So we can see right here, it's kind of like the semilunar valves in here, where we're having some active contraction right here so that we can force all of that blood up and out. So the ventricles contract, those AV valves close, the chordae tendineae tighten, preventing the valve cusps from entering into the atria. So all while this is going on, we have blood filling up in the atria, up in here. And then as ventricles contract, these semilunar valves open, pushing that blood up and out. Here's a little bit better picture of those semilunar valves. You can see that cup shape that I was talking about, how it can use that blood as a passive valve. As the ventricles relax and that pressure falls, blood backflows, but those semilunar valves catch it. And then we repeat the cycle all over again. So this blood flow is something that I'm holding you responsible for. And we're going to make it just a little bit simpler here. So, first, venous blood enters the right atrium. Second, the right atria contracts. Third, blood passes the tricuspid valve and enters the blood passes the tricuspid valve and enters the right ventricle. Number 4, the right ventricle contracts and pumps blood past the pulmonary semilunar valve through the pulmonary arteries. Number 5, oxygenated blood returns through the pulmonary veins into the left atria. Number 6, the left atrium or left atria contracts. And 7, blood is pushed through the bicuspid valve into the left ventricle. And last one's 8. The left ventricle contracts and launches blood past the aortic semilunar valve and through the ascending aorta. You will be tested on this specifically. This is why there's a star on this slide in particular. The way I would suggest studying for this is to go through it regularly and typically write it out. Is how students have, I think, most effectively studied for this in the past. All right. Through the ascending aorta. Did I spell that right? A-O-R, yeah, aorta. So number 1, venous blood enters the right atrium. Number 2, the right atrium contracts. Number 3, blood passes the tricuspid valve and enters the right ventricle. Number 4, the right ventricle contracts and pumps blood past the pulmonary semilunar valve through the pulmonary arteries. Number 4, the right ventricle contracts and pumps blood past the pulmonary semilunar valve through the pulmonary arteries. Number 5, oxygenated blood returns through the pulmonary veins into the left atrium. I think it's really important for you all to remember the difference between pulmonary arteries and pulmonary veins in particular. Number 6, the left atrium contracts. Number 7, blood is pushed through the bicuspid valve into the left ventricle. Number 8, the left ventricle contracts and launches blood past the aortic semilunar valve and through the ascending aorta. All right. So here's just another different view. We have now cut open that right atrium. We can see this venous blood returning through the vena cava, push through that tricuspid valve, ventricle contracts, pushed out the pulmonary semilunar valve, blood flows to the lungs, goes into the lungs. We're then returning from the lungs, oxygenated flow through the pulmonary veins into the left atrium, through that bicuspid valve, left ventricle contracts, pushed out through the aortic semilunar valve and up and out the ascending aorta. There's a reason they've essentially spent this entire time on blood flow. Nail it into your head. Because you will be tested in the order specifically. You'll have to put each of them in order. I don't remember. Be comfortable enough. If you're comfortable enough writing it out, you will be fine. All right. Everyone good on blood flow? I think I'll leave that for today. That's a lot. Remember, if you haven't already, to schedule time to take your second muscle exam. This content specifically for cardiac will not be tested until after break. So if you want to put this on hold, you can. Remember to schedule your third muscle exam with me if you haven't already. That'll be lecture for today. Any questions before I stop the recording? All right.